Hello, everyone, and welcome to the September NASGP webinar, which will also be produced as a YouTube video and a podcast. And this month's topic is on prostate cancer. And I'm joined by Dr. Bunmi Olajide, who is a GP with a passion for improving cancer services. He's a keen interest in raising awareness and transforming GP cancer education, and is a Prostate Cancer UK clinical champion, works to raise awareness of prostate cancer, particularly within the Black ethnic minority group. So, Bunmi, huge welcome. Thank you so much. We've been preparing for this talk for a long time now, so really delighted to have you along today.
Thank you, Richard. And I am delighted to be around today. It's a huge opportunity to speak to colleagues, and I think it's a great platform you've got here, able to reach as many colleagues as possible. Prostate cancer is something I hold dear to heart, and so every opportunity to speak to colleagues is taken with a lot of gratitude. So thank you. Thank you. Good afternoon, everyone. My name's Bunmi Olajide. I'm an GP in Romford, that's the Greater London area. And as said by Richard, my interest is in cancer, more specifically prostate cancer, over the past 4 years now. And I do a lot of work around education for GP trainees and GP colleagues, and also raising awareness, particularly within the Black ethnic minority group. My role with education also crosses with my role as a training program director for the local patch. So, yeah, interest in cancer and that interest in education is what's been the driving force. The talk today will be on early detection of prostate cancer within the primary care setup. So the learning objectives today really is the main risk factors for prostate cancer. Yeah, we learn about that. Also understanding the key health inequalities or inequities in prostate cancer. And then hopefully we're able to assess and reassess the need for the PSA blood testing. That's always a hot discussion. And hopefully we can assess and reassess that within our talk today. And also, the plan will be to explain the prostate cancer diagnostic pathway. And this will be touching on how the pathway was and what we have more recently. The objective also will be touching on understanding the limitations with the digital rectal examination, specifically for assessing prostate cancer. So the limitations of the DRE in assessing prostate cancer. And then hopefully we can round up with identifying kind of where as GPs we can get more information for ourselves and for our patients. So starting the talk, it'll be good to know what the scale of the problem is when we're talking prostate cancer. Yeah, so talking about the scale, we know over 55,000 cases are diagnosed annually. We know prostate cancer is the most common cancer in men. So it's clearly overtaking lung cancer, which was the most common cancer in men a few years ago. We have around 12,000 deaths annually in the UK alone from prostate cancer. And it's the second biggest cancer killer in males in the UK. The only high incidence cancer, so if we look at kind of all the other cancers that have a high incidence in the UK, if you look at prostate cancer, it's the only one without an approved screening program. And we'll come to touch on that kind of later on. So of the high incidence cancers, prostate cancer is the only one without an approved screening program. There's a rising diagnosis, and that from what we're seeing is a pointer to greater awareness, and also there is more informed decision around PSA testing for men. As things stand currently in the UK, over 440,000 men are living with or after treatment for prostate cancer in England alone, 440,000 men. So that's the sheer scale of what we're dealing with when we're talking prostate cancer. Risk factors, we know all over the world, the risk factors are the same, but going into specifics with kind of figures, in the UK, 1 in 8 men will be diagnosed with prostate cancer in their lifetime. We know it affects mainly men over the age of 50 and over, so age is a factor there. A man has a 2 to 4 times increased risk if they have a family history of prostate cancer. And I'm talking about 1 or more first-degree relatives. Now, we've talked about 2 to 4 times because if it's 1 first-degree relative, the risk is about 2 or more. If it's 2, say a brother and then one's father is diagnosed, then that risk can go up to 4 times. And this is irrespective of ethnicity. So for men, 2 to 4 times more likely to be diagnosed if there is 1 or more first-degree relative with prostate cancer. There's also the risk if there is a family history of BRCA1 or BRCA2. So as GPs, we know at times men will talk about, oh, they've got family history of breast cancer, ovarian cancer. Might be what kind of digging in a bit more into that, just to say, okay, family history, breast, ovarian cancer. Have you heard about BRCA gene, or is this something you're aware of? Or have you been told it's the BRCA gene? Because if that's the case, there's an increased chance of that man having prostate cancer. And talking about ethnic background, studies have shown that Black men are more likely to get prostate cancer. That's 2 times more the general risk. So we've got 1 in 8, but for Black men, it is 1 in 4. So the risk is 1 in 4 for Black men of getting prostate cancer during their lifetime. So what do our guidelines tell us? We've got the NICE guidelines, and it's talking about suspected cancer, recognition, and referral. What we know about the guideline, it is largely symptom driven. So the patient would have to have symptoms, present at the GP, and then you manage them accordingly. So the NICE guidelines is symptom driven. And it's what drives most of our 2-week wait referrals. So majority of GPs will be guided by NICE in making referrals. So it's the faster diagnosis referrals, as they're called now. There was an update in 2021, and I'll come to touch on this. And what we know with the update is there's the recommendation for the age-specific PSA thresholds. So for certain age groups, a PSA levels at which you make a referral is specified. And that came with that update. So if we touch a bit more. So if you look at prostate cancer under the NG12, it talks about referring people using the suspected cancer pathway for prostate cancer if the prostate feels malignant on digital examination. Okay. It also talks about considering a PSA test and a digital rectal examination to assess for prostate cancer in people with any lower urinary tract symptoms. And they gave the example there: nocturia, urgency, irritation, frequency. It talks about doing this if you have patients with presenting with erectile dysfunction, or if you've got patients presenting with visible hematuria. Now, take note of the consider. Okay, so a lot of kind of the guidance with NICE is based on evidence. So once you start seeing consider, and it, you know it's really different from when they say you should or you must refer. So this is consider. Okay, and touching on the update in 2021 and the age specific referral thresholds, it talks about consider referring people with possible symptoms of prostate cancer using the pathway and in line with those figures for the age. Now, I would say that for this, the threshold is clearer after this update because there is the specific PSA levels for those certain age groups. Okay. However, we know from kind of what has been done across the patient by the PCUK that this is not the case across the whole of the UK. It varies depending on what part of the UK you are in. Lower urinary tract symptoms. We talked about the NICE guidelines being quite symptom driven. So you have to have a symptom present at your GP and then a referral is made. So there was a work done by the National Cancer Diagnosis Audit in 2014, and it looked at just over 1,100 men with lower urinary tract symptoms. The findings were that 60% were found to have prostate cancer, 50% of men with lower urinary tract symptoms who had presented to the GP and had a PSA test, 60% of them were found to be in stages 1 and 2, and 82% stages 1 to 3. Now, if we look at that, there's still a chunk of men outside that 60% who have not been diagnosed as stages 1 and 2 when they presented with lower urinary tract symptoms. So this suggests there may be an opportunity here to diagnose prostate cancer earlier for men. But there are men who present requesting for PSA test and they've got no symptoms. Okay. And the Office of Health Improvement and Disparities have a guidance for GPs to consult on the pros and cons of PSA testing in men who present without symptoms. Okay. It is reactive if you look at this. So the emphasis is around men who present. So that the men have to present before or really ask about the test before we have these discussions with them. So men without symptoms, if they don't ask, there's a lot of opportunities missed there. They talk about GPs not proactively raising the issue of PSA testing with asymptomatic individuals. We know the PSA test is available and it's free to men who request it. With this guidance, there's no recommended PSA threshold. Okay. However, it touches on most men would be expected to have a PSA level below 3. And this is the prostate cancer risk management program. Okay. So let's touch on the prostate cancer risk management program. It's a guidance and it was updated December 2024. I've touched on the PSA test being available for men free, and that's what the risk management program touches on also. The update went further, and in this case, it included trans women and non-binary people. Now, it talks about GPs using their clinical judgment in managing asymptomatic men, and those who are considered to be at increased risk of prostate cancer. That's the introduction from the updated guidelines. In the absence of symptoms, GPs are expected to discuss the pros and cons of PSA testing with the patient. However, if the patient is presenting with symptoms, then GPs are expected to refer to the NICE guidelines. Okay, so PSA blood testing. What do we know about the blood test? The pros? We know it could lead to detection of cancer before symptoms develop. So a PSA test result could actually lead to the detection of cancer before your patient presents with symptoms. It may lead to the detection of cancer at an early stage, okay, when there is a lot that could be done for the patient. Repeat PSA testing provides valuable information aiding the prostate cancer diagnosis. And again, we know with PSA testing, it is what's used by secondary care colleagues in monitoring patients even after treatment. So the PSA is still used to check, is there relapse or is the levels going up again, and there needs to be a change in treatment. That the PSA blood test is used for that. What are the cons? We know it is not specific for prostate cancer. Okay, so a man may not have prostate cancer and the PSA levels may be raised. So it's not specific for prostate cancer. Around 75% of men with a raised PSA level may not have cancer, 3 in 4. We know a smaller proportion of men who have a low PSA level could be found to have prostate cancer. So that's the bit about the PSA test. It's not giving us all the information we need, okay? But we know it is the starting point. And remember, it may lead to detection of cancer before symptoms develop. So that quarter of men, we don't want to miss them. And we know the PSA helps in that sense. So other factors to consider when we're thinking PSA, we could have increased PSA levels due to a number of factors. And I know as GPs, we talk to patients around is when they have the PSA test, we want to be sure they've not got an infection. Someone is a keen cyclist and they're doing hours or long periods, I'd say greater than 30 minutes on the bicycle riding, then yeah, that could impact in some cases. So it's good to make the man aware if they're going to have the PSA test. We know also some studies have come to show that you could have a slight rise in the PSA with men who've had testosterone replacement therapy, who are having it actually. And that's particularly with the injection form. So with the tablets and the gels, there isn't much kind of to support that you would have an increased PSA level, but something to watch out for as GPs. On the other side, you could have decreased PSA levels, and so it could be falsely suppressed by the 5-alpha reductase inhibitors. And this we can have in some antibody treatments that your patients accessing online. Finasteride, dutasteride, those medications could give a falsely suppressed PSA reading. Our urology colleagues will talk about kind of considering a factor of 2. So if a patient is on finasteride, you're considering 2 times the levels you're seeing. So if their levels are 3, you're thinking there's a chance that this PSA level actually could be 6. So again, for our patients on medicines like that, or even if we don't know, it's worth asking, are you having anything over the counter for your hair, and knowing what they're having, because the PSA levels could be suppressed due to this. And some studies have shown the impact of obesity on PSA levels. You could have a slightly lower level. So, touching on inequalities and inequities uh, within prostate cancer. So, we know Black men have double the risk from both the diagnosis of prostate cancer and from dying with prostate cancer. Also, they have a higher risk of developing it at a younger age. So that's something to keep in mind. Presentation with metastatic disease has been linked strongly with deprivation. So patients from the most deprived areas tend to present later and diagnosed at stage 2, stage 3. Stage 3, stage 4, at later stages at diagnosis. A study done showed that variation could be up to about 30%, okay, when you compare those from the least deprived to the more affluent regions. And that table on screen just shows kind of the variation you can see. So there is a wide geographical inequity when we're talking about prostate cancer diagnosis and the presentation of patients. So PCUK, working with patients and specialist groups across board, so primary care physicians, secondary care, epidemiologists, oncologists, have come up with a position statement. And that is, because Black men have double the risk with prostate cancer and higher risk of being diagnosed at a younger age, it is recommended strongly that they speak to their GP, actually not from the age of 50, but from the age of 45. And this would apply also to men with a known family history of prostate cancer or the BRCA gene. So that's the National Prostate Cancer Audit State of Nation report. And it highlights key data. So we're still talking around inequalities and inequities in prostate cancer kind of diagnosis. And it highlights variations in prostate cancer care and services across providers in England and Wales. And the figures on screen kind of points to that. So in 2023, 55,000 men were diagnosed with prostate cancer. Now, that was an increase of 9% compared to the figure in 2022, which was 50,000 men. Now, if you go to Wales in 2022, just around 2,500 men were diagnosed with prostate cancer, compared to about 2,000 men the year before, and it shows a 26% increase. So 9%, 26%. Okay. And that goes on again with disease presentation, okay, where you've got 17% in England compared to 19% in Wales. So this presentation is touching on late presentation, okay? Late presentation. Diagnosing prostate cancer. What's changed with the diagnostic pathway? Before 2019, what would happen is a man presents, they have a PSA blood test, it shows a raised PSA level, there's a suspicion of prostate cancer, they're referred, and what they would have is a biopsy. And that would be a transrectal biopsy. And I can remember kind of back in those days when my patients come back and they talk about the number of samples they had to be taken from the prostate. Okay. So, and again, it's transrectal. So we can start thinking around the risk that is posed with that. So PSA blood test, biopsy, multiple biopsy sites taken transrectally. The change is now what we know is that if a man presents to the GP, has a PSA blood test done, what is done next is a multiparametric MRI scan, and following that, what they have, if the MRI scan shows there is need to have a biopsy, what they would have is a transperineal biopsy. So just to highlight that in clearer details, there's the PMRI prostate cancer diagnostic pathway, and there is a post-MRI prostate cancer diagnostic pathway. Now, there was a study that looked at the 3 largest prostate cancer screening trials. So it looked at the CAP, that's a cluster randomized trial of PSA testing for prostate cancer. We looked at the ERSPC, the European one, and the PLCO, so the prostate, lung, colorectal, and ovarian cancer screening trial. Okay, now following the pathway, looking at the ERSPC, it showed a 20% reduction in prostate cancer specific mortality for men who were screened versus men who were not screened at 16 years follow-up. The PLCO found no difference in prostate cancer mortality. Okay, but evidence came to show that there was significant contamination in the control group. The ERSPC and the CAP also showed that screening associated with harms, or the screening was associated with harms. So unnecessary biopsies, we talked about pre-MRI, it was the transrectal. So there was the risk with sepsis, higher overdiagnosis rate, and higher overtreatment. So overdiagnosis coming with overtreatment. Okay, what difference has the current pathway made? Evidence has shown that pre-biopsy multiparametric MRI, it reduces the number of men who have unnecessary biopsies. Okay, so a PSA, you have the NPMRI, and you go to having biopsy where it's indicated. So the MRI then selects, you're able to kind of rightly select the group of men that then need to go ahead for biopsy. Okay, it also helps help in reducing the number of clinically insignificant prostate cancer diagnosis. Yeah. So there is a 40% and rising of 40% the number of prostate biopsies that are now done transperineally. So it's not caught up everywhere, the move to transperineal, but it is rising the number of centers that are using transperineal biopsies, and that's reducing the risk of sepsis. So let's look at real world data. Prostate cancer UK analyzed data from 16 hospitals in London and the southwest area of England. And what it shows that there is a reduced harm to men, okay, with the modern pathway. And I'll come to kind of show this looking at this table, okay? So we're looking at pre-MRI, we're looking at the modern pathway model and real-life data, and you would see really the difference there. So if we're looking at, for example, the number of men who had a biopsy and showing no cancer, pre-MRI, about 9.5%. In actual practice, we look at the Southwest, that was reduced to 1.52%. If we look at men who suffered with sepsis, pre-MRI, just about 0.1%, with the modern pathway, 0.07%. And when we look at real life data from from actual practice in the London area, 0.02%. So you could see the huge difference, variation. And just put simply, this next slide just puts it simply here. So this slide actually just put it in clear, simple terms, kind of what it means, pre and post, and everything I've been talking about since. What we know is advances in technology has reduced the risk of harm when we're talking prostate cancer. And that reduction is 79%. So if you're comparing the pre-MRI to post-MRI. And today, 90% fewer men develop sepsis after a PSA blood test. We say after PSA blood test because we know the first thing that is done is a PSA blood test. And if it's high, then we have to refer. So it's a 90% reduction. The risk of sepsis. So that is massive. To DRE or not to DRE, a digital rectal examination. So there's a paper produced on the British Journal of General Practice last year. It just rounds up kind of what the recommendation would be. And is the PSA, is the digital rectal examination an effective screening tool when we're talking about prostate cancer? The answer is really no. We know it's poor sensitivity-wise and specificity-wise. We know it really doesn't add much value beyond the PSA. If the PSA levels are raised anyway, as GPs, I'm not sure if we will be changing our decision on the next steps following a digital rectal examination. So if I have my patient and the PSA levels have come back raised, say, for example, I decide to still go do a DRE and the prostate feels normal, I'm not going to change the next steps for managing that patient. I'm not going to ignore that raised PSA level. So the digital rectal exam in that sense does not add additional value beyond that raised PSA. The NICE guidelines now recommend the multiparametric MRI for first line after referral. Okay, so do we still really need doing the DRE? It is found to be helpful in certain instances. So we have our patients, they have asymptomatic or even symptomatic. We've done a PSA test, it's normal, but we're thinking other prostate conditions, or the patient is an at-risk patient and we feel, okay, the PSA levels are normal, but I'm still kind of worried about this patient, then please do a DRE. Please do a DRE in those instances. But aside that, I think what we've seen is it's kind of a real put off for men, and a lot of men have been put off coming to their GP because they just kind of assume that it is automatic. If I'm concerned about prostate cancer, my GP is going to put the finger up the bum, and they don't show up. And we want to remove this deterrent from men, but also it's helping our own practice as clinicians to say, what difference does it make? So again, just touching on the role of the DRE, we know now it's multiparametric scans, and we have newer biopsy techniques. We know it is a poor test for prostate cancer, and I think it's just taking note of that. So, how has PCUK looked at supporting us as GPs, supporting our nurses, supporting our patients? This next slide talks about the consultation toolkit. So, if there's anything we kind of need generally, information around supporting our patients, discussing with our patients, key information on treatments, updates on treatments. It's a really useful link. And I think you could scan that code there, and it would direct you straight to the link. There's also good CPD for those who are keen on that. So a lot of online learning, which is really helpful. Yeah, and for healthcare resources, healthcare professionals, just what I touched on. So e-learnings, um, these QR codes would be shared, but again, if you're able to just uh, get onto them, it's really useful. Also, there's information on support PCUK offers with kind of improvement programs, and also the clinical champions program, which is a training course I went on as a GP myself, and I can tell you transformed me generally as a GP. So this is not just talking prostate cancer, but the leadership qualities it brings. It consolidated everything I've learned as a GP. So it proved me as someone with a special interest in cancer and prostate cancer, but also kind of leadership across board. It's a great opportunity to network, meet with professionals across the NHS platform. So oncologists, urologists, physiotherapists, nurses, nurse specialists. So again, for those who want to follow or follow a career in special interest, that will be one to consider. Again, signposting patients for information. So even your patients with prostate cancer, the PCUK specialist nurse services are known to be top notch. And there is just a lot of information. They offer support to patients. So if your patients are coming in, you can signpost them for support. A lot of this you can get from the PCUK website. I'll quickly touch on the Transform project. Okay, so the Transform project is a UK-wide prostate cancer screening trial, and there will be recruitment from the autumn this year. What's been invested in to this trial is huge. I'm talking £42 million, and that's funding from Prostate Cancer UK and the UK government via the NIHR. And the vision really is to test modern approaches beyond the PSA. So we know the PSA has got its flaws, but it's testing modern approaches to early identification of prostate cancer beyond the PSA. And the drive is to make sure that the benefits outweighs the harms. Okay, the stage 1 is ongoing in England, and that will run until 2028. GPs will be involved with the stage 2, so you can express interest, and the way to go through by this is either to your secondary care side or contacting Prostate Cancer UK. It's a huge project, and we're looking at that would really help provide definitive evidence, which would lead us to the safest and most accurate method for screening. Now, the UK National Screening Committee are kind of going to be coming up with a statement pretty soon, towards the end of the year. So that could impact what the guidelines are going to be, or kind of what the future will be around screening for prostate cancer. But irrespective of the outcome of the National Screening Committee, irrespective of the decision, Transform is here to stay, and it would really help with modernizing our approaches beyond PSA. So, take-home points: since the 2019 NICE guidelines update, prostate cancer diagnosis and treatment pathway changed to make it safer and more accurate for patients. The PSA blood test, it is the first step in the prostate cancer diagnostic pathway. It is what we've got now. We know it's cheap, we know it's safe, and we know it's an effective way in identifying men who would benefit from further testing. So before you get to your MRI or the biopsy, the PSA test is the first test. Prostate Cancer UK is working to reach and activate higher risk men, support them so that they can make informed choices about whether to have a PSA blood test or not. Okay, and that is me done. Thank you.
Bunmi, that's wonderful. Thank you so much for that, Dr. Olajide. That's really interesting. You're clearly an educator. That was beautifully explained, very calmly, very succinctly. I came to this with lots of questions, but you kind of answered them all, which is wonderful. I'll quickly. There's a couple of little points in the chat. So David is in Wales, and David has said that progress is promised by the Health Secretary, indicated by next year neonatal full genome screening will accurately predict date of diagnosis and deaths. But is there in fact some genetic test that can accurately predict higher risk, or is this just the BRCA1 and 2 genes? And can men have this gene sequencing done, or should we refer to our genetic services?
Okay. Great question. And now, in answering this, I'll touch on the transform also. So what we know, yes, there is some genetic predisposition in cases with, in certain cases with prostate cancer. And there are a lot of research being done currently. I think there is a lot for us to still learn about prostate cancer and those genetic sequences and those specific genes also. I'm not sure what the genetic services in Wales offer, but I know definitely for England, I'm not sure they will be able to support much with that. But this is part of what the Transform is looking at. And there are pockets of research ongoing. I know the Marsden is running one for men also. So there are opportunities there for those who would be willing or interested in taking up that opportunity.
Fantastic, lovely, thank you. I've got a couple more questions, a couple more points, but before I do, I just want to mention we're going to send everybody a link to do a quick feedback for Bunmi. I'd be really grateful if you could do that. It could be so helpful for Bunmi and for Prostate Cancer UK. You're working really closely with us to get this presentation out there, so that would be great. We're having people saying, Samra says, great talk, as does David. Gayatri says, great presentation, thank you. We have AD says, why are referral forms still having rectal exam to be completed? Got a good point about the relevance of rectal exam to management plan with a raised PSA.
I think for GPs general, we would all ask that question. Yeah, there've been discussions around kind of the referral forms and the mention around DRE. As I said, we're not saying absolutely do not. We're saying here for prostate cancer, if the patient's concern is prostate cancer and they're coming in and saying, I want a PSA test, the digital rectal examination, it is not going to add any more value. And I give that example, and I'm sure for all of us, it will be the same as GPs. If that PSA level is raised, even if we then still do the DRE, we're not going to go, well, I felt round and the prostate, I can't feel much. I'm not going to, forget about the PSA, your prostate feels normal. No, we're not going to do that. So it's that added value. I think when I was speaking with trainees, I gave an example of me coming through medical school and learning a lot about the vocal fremetus. You put your hand on the chest and you tell them to say 99 or something, and you see, we don't we don't really use much of that now. So yeah, and the DRE, again, how many people feeling the prostate can definitively say that they are sure what they're feeling around the prostate. So rather than it putting off our patients, I think, yeah. So yeah, the same question I would ask. I don't know why it's still there, but yeah, I think with time we know guidelines change, and with more evidence, then maybe that will change. Yeah.
That's great. Lovely, Bunmi. Thank you so much. A few more thank yous and very positive feedback. So thank you everyone for coming along to this month's meeting. Look out for news about next month's meeting as well. We will put this out as a YouTube and even a podcast, and in the show notes we're going to put in Bunmi's links there as well. I particularly liked your link, Bunmi, about the leadership program. It's really it's brilliant to have fellow GPs like you doing this, and it's really inspiring. So thank you so much. And so everyone, thank you very much. We'll leave you. Take care, everyone. Goodbye.